Hi, I'm Dr. Asma Javed from Mayo Clinic, Rochester, Minnesota, lead author of the clinical review on female athlete Triad and its components toward improved screening and management. First of all, I'd like to thank my esteemed co-authors, Dr. Ida Latif, Dr. Peter Tebben, and Dr. Phil Fisher, for their excellent contributions to this manuscript. The purpose of this clinical review was to highlight the current gaps in knowledge for physicians, athletes, their families, trainers, and coaches regarding the female athlete triad, and to also outline a management and screening algorithm for primary care physicians and specialists when dealing with females at risk for or suffering from the female athlete triad. Female athletic participation in the last 40 years has increased considerably. Along with this increase in female athletic participation has come a unique set of challenges for these female athletes. It wasn't until 1992 when the American College of Sports Medicine first defined the female athlete triad as a condition comprising three components: eating disorder, amenorrhea, and osteoporosis. It has long since been recognized that the female athlete triad is more than a combination of these three finite components. An athlete at any given point of time can lie anywhere along the spectrum of disordered eating or low energy availability, be that inadvertent or intentional, could have any form of menstrual dysfunction, and varying degrees of bone mineral density loss. Additionally, it has been recognized that a significant minority of physicians consider menstrual dysfunction to be a normal consequence of exercise, and we emphasize that this is not so. Menstrual dysfunction occurring in an active woman in the context of exercise is usually due to a lack of energy availability. The actual prevalence of the female athlete triad is low, anywhere between 0 to 1.2% in U.S. high school and collegiate athletes. However, the prevalence of its components is quite high, with up to a quarter of active women experiencing some form of menstrual dysfunction, 18% admitting to some form of disordered eating or low energy availability, and 4% experiencing bone mineral density loss despite the beneficial aspects of exercise on bone health. It's important to recognize that the female athlete triad does not just occur in sports and could occur in women of all ages across all sports, including recreational exercisers. Through recent surveys and studies, it has been identified that there exists a large knowledge gap among physicians, coaches, trainers, athletes, and their families regarding the female athlete triad and its components. In recent surveys, only half of physicians and less than 10% of trainers and coaches could correctly identify the three components of the female athlete triad. The pre-participation and evaluation form is similarly ill-equipped to diagnose and screen for the female athlete triad. The Female Athlete Triad Coalition recommends 12 screening items to be included in all pre-participation evaluation forms for active girls and women. However, most of these screening items are not incorporated in the current screening questionnaires and are not implemented regularly. Therefore, we highlight in our article the importance of early recognition and prevention of the female athlete triad by incorporating these screening items into current pre-participation evaluation forms. We emphasize in the article that energy repletion remains the cornerstone of management of the female athlete triad. Pharmacotherapy, be it calcium and vitamin D supplementation or the use of oral contraceptive pills to restore menstrual cycles, has been shown to be of minimal benefit. Consistently in studies, the one therapy that can restore both menstrual function and bone health is energy repletion. This repletion of energy can occur only in the context of a close-knit relationship between the athlete, their physician, coaches and trainers, as well as a dietitian, preferably a sports dietitian. We outline in the article screening and management algorithms for primary care physicians and specialists to follow when evaluating females at risk for the female athlete triad. Additionally, we emphasize educational efforts, both in educational institutions and in physicians, to make sure that the condition is screened for at appropriate intervals and managed appropriately. For further information on these screening and management guidelines, please refer to our article. Thank you very much for your attention.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, Our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.